Hi everyone, it's Renee Gifford again. We're going to be continuing on with our advanced programming modules. We're going to be focusing primarily on objective measures today. So we're going to be looking at the most common objective measures that are used in clinical cochlear implant programs and basically looking more at what the actual relationship is between these objective measures and the behavioral upper and lower stimulation levels that we might get, as well as really we're going to discuss the clinical utility of each of those measures a little bit more in depth in the next series, which is just going to be a series of case studies of actual patients I've seen myself, so that we can go over where, for example, ECAPs or electrically evoked compound action potentials and electrically evoked stapedial reflex thresholds may play into the fitting of upper and lower stimulation levels. So moving right along, we're going to talk about, first, we're going to focus on the electrically evoked stapedius muscle reflex, or ESRT. And so I've seen it with little e, big E, I've seen just ESR. I'm going to just be referring to this as ESRT from this point forward. And then after that, we'll talk about the ECAP, which is usually referred to as NRT, NRI, ART, which is just really sort of the marketing terms that each of the cochlear implant manufacturers has chosen to use for what really is just an electrically evoked compound action potential. So moving into ESRTs. Okay, so I know this is a really busy slide here, but the reality is stapedial reflex thresholds, which we know we use with acoustic stimuli in a hearing clinic all the time, can be elicited with electrical stimulation as well. We can measure this with a probe in the non-implanted ear, which is most preferable for a lot of reasons, which we're going to talk about in a moment. But we also can measure this with the probe in the implanted ear. As you recall from your days with standard hearing assessments, when you're doing any type of admittance testing, the patient does need to remain pretty still. You basically tell them try to avoid swallowing, at which point they immediately have to swallow, the power of suggestion. And then you want to have them sort of avoid talking and excessive head movements. Of course, what is critical before we do any ESRT testing is we have to verify that the middle ear function, at least in the probe ear, is normal. If the middle ear function in that ear shows negative pressure or really no middle ear mobility whatsoever, like a type B tympanogram, we really can't measure ESRTs, at least not with the probe in that ear. So what I typically do in that case is I'll take the probe and place it in the implanted ear, run a tympanogram. If that ear looks fine as far as middle ear mobility, then I'm going to go ahead and try that ear. But this, of course, gets a little sticky because we know, especially our youngest patients tend to have middle ear issues with fluid or negative pressure, and we've got a lot of kids, of course, who are going to have PE tubes, which is not going to work for measuring ESRTs. So basically what we're doing is we're going to start at a stimulation level that's generally below where we would expect their upper stimulation level to be, or their C or M level. So we're going to start nice and low, and then we're going to kind of stimulate in about 3 bursts and just kind of slowly increase the level of the stimulation until we can see a change in admittance on the acoustic reflex decay screen, because that gives us a nice long time window. You basically would decrease the level of the stimulus until you see the ESRT disappear. I'm going to go through, we're going to look at some examples in a moment. I also want to point out, if you're not familiar, and although this is not used very often, you can actually measure intraoperative ESRTs, which are typically done visually. So what we often do is have the surgeon or one of the residents, or even a medical student, if one is present, can look through the scope and tell us if they see an actual physical contraction of the stapedius muscle. This is a really useful tool in patients who are multiply involved, who are not going to give us a really great behavioral response to sound. And for those who we are just going to be concerned with compliance, as far as like try to keep your head still, try not to swallow, try not to talk. So this is actually a really nice tool to use, and you get a really nice correlation between what your ESRT levels are and your upper stim levels. I do want to point out that this is a threshold, though. I'm sorry, this is a reflex. It's been a long day. This is a reflex, and like with any reflex, when there's been any anesthesia in the system or anything that is designed to repress the system, you're going to see a elevation of the threshold, or that reflex threshold. So if the person is under general anesthesia, we are going to expect that those ESRTs would be higher than they would be had the person be conscious. And I've also heard that some other muscle reluctance can also cause a depression, and then that would require higher stim levels to get that ESRT. Well, let's move on and look at this a little bit more carefully. So what you see on this figure is, this is the nice acoustic reflex decay window again. So you have the nice 10 to 15 second time window. This was actually taken from the Wolf and Schaefer 2015 book. It's figure 311. So what you're looking at here is, right here, I want you to look at my cursor here. You can see that, I think, oops, I need to go back. I'm going to draw on this pen. Here we go. So I want you to focus right here. There you go. So that would be a clinical level of 196, and there's no response. So there's no change in admittance there. Now, with stimulus level of 198, you can see this nice time-locked stimulus with 3 bursts of stimulation. So beep, beep, beep. Just to verify that it's there, they increase the level to 200 clinical levels. And you can see the response grow here, 1, 2, 3. Further increases in stimulation level to 202 clinical levels. And again, you see the response growth increase, greater response. So basically, it's pretty simple, with the exception of it can be a little complicated because you are running 2 pieces of equipment at the same time. So you're stimulating on the cochlear implant software, you're measuring on your admittance software, but it provides you a really nice physiologic response, or an objective measure, that really gives us an idea of where those upper stim levels should be set. So moving to the next one. Here we go. So this is, as I mentioned, you do need an extra piece of equipment, right? So we've got our computer here on the left. You have your computer programming interface, which is like your CPI or your pod or your Maestro. I'm blanking on the term at the moment. I'll come back to it in a moment for MED-EL, the box. And of course, you need to have the coil on the head. You're going to be placing the probe in ideally the non-implanted ear. Although, as we mentioned, you can place it in an implanted ear, and given that more and more people have bilateral implants, it's becoming a situation where we're finding ourselves having to measure ESRTs from an implanted ear. But you do need, as shown here, is an impedance bridge, but is really typically actually more of an admittance bridge. And this is from Hughes' book, 2013, figure 6.1. An excellent book. I highly recommend it if you're interested in objective measures and you want to get a little bit more information than you're going to get in today's lecture. Really great book. Okay, so here's another example also from the Michelle Hughes book. So I'm going to get my little pen out. Okay, so what you're looking at, this is just kind of like the printout. So here, starting at 189 clinical levels, this is on electrode 10, and really not any activity there. Going up to 192, so she went up in 3 clinical level increment. Maybe starting to see a little bit of a response there. Going up to 194. Beautiful. You can see that this response here, this change in admittance, is time-locked with this signal, which they have demarcated here. Going up to 196, just like with an acoustic reflex, as you increase the level, you should expect that response to grow, and in fact, it does, as shown here. So in this particular figure, what they explain is that, of course, these are no responses here. At 194, this is definitely a measurable ESRT. At 196, you can see nice response growth. So in reality, the threshold is probably somewhere in between here. So probably about at 193, 194 clinical levels. And that's what there is to it. Now, As you all know, at least for adults, when we do tympanometry and when we do acoustic reflex testing, we're typically using a probe tone of 226 hertz. The reason that we do this is that we typically are going to be using a probe tone that is not equivalent to the resonant frequency of the middle ear system, so that we can look at different properties of the system. So if you can remember back to your old audiology classroom days, the resonance frequency of the middle ear system in adults, it can range anywhere from like 600 to 700 all the way up to almost 2,000 hertz. So what we typically do in tympanometry and in any admittance testing with adults, we typically default to a probe tone frequency of 226. And what that does is it allows us to focus on the stiffness dominated system. And what that shows is if there's any changes to the stiffness of that system, you're likely going to see an effect with that probe tone at that low frequency. So think about it with a cochlear implant recipient. So let's look over here on the left side of the figure. This is actually an endoscopic view of the round window. So the round window, I'm going to get my pen out. So the round window is right here. I'm going to highlight it here in red. Maybe not the best choice of since it's all red there, but that's the round window. It's beautiful. It's just kind of staring at you right there. And this is through the facial recess, if I didn't mention. So you got your round window. Up here you got the malleus umbo. Over here is the incus. This is the actual incus bone. And then you've got the stapedius tendon here. So this is a nice beautiful view of the round window before an electrode is placed, because as you can see over here on the right, we all know that cochlear implant electrodes actually do reside, at least the lead, not the electrodes themselves, but the electrode array lead lives in the middle ear space. That's how they insert it into the cochlea. So imagine if we're measuring, if we need to place the probe in the implanted ear. Well, you can probably guess that there's going to be some changes to the stiffness of that system. So especially if this electrode lead touches the bones of the middle ear system in any way. And it can happen. You know, the surgeons do typically tie things down to try to keep it out of place, but the electrode lead is really coiled around, and there can be some movement of that lead in the middle ear system. So we know, and also of course the ear's been operated on, so there's some changes inherently to the mechanics of that system. So it's very often that people might try to get an ESRT using the typical probe tone frequency 226, and they don't really get anything, or they get you know, kind of a messy response, and they think, well, this is one of those people that I can't measure an ESRT for. But if you can change your probe tone frequency up to 678 or even all the way up to 1,000 hertz, you're going to potentially increase the likelihood that you will see an ESRT. And we're going to get to that a little bit more in depth in a moment. But it's important for us to remember we have more people with bilateral implants, which means more people for whom we're not going to be able to place a probe in a non-implanted ear. And so thankfully we've got a lot of options at our disposal with our admittance systems that we can try different probe tone frequencies to try to get around the fact that that middle ear system is essentially altered mechanically in some way and can affect the response that we measure. Okay, so what I'm showing you here is we're looking at stimulus level on the left, or the y-axis. So we've got stimulus level in clinical units. And then along the x-axis, this is duration of implant use in days. So I have recreated some of these data that appeared in this Gordon et al. 2004 paper from Ear and Hearing. And what you're looking at is on the bottom here, so these black dotted bars represent, or black dotted line represents behavioral thresholds that are measured with the participants in the study. And the blue upper line represents the behavioral upper stimulation levels, or C or M levels, for these patients in the study over time. So typically what they see is that, you know, lower stimulation levels are relatively constant. Upper stimulation levels tend to increase a little bit over the first, you know, half year or so, but then do tend to level off. Shown here then are the sort of the relationship of the ESRTs here in these red symbols in relation to the upper stimulation levels over time. And what you can see is that by about midway little over midway through the first year of implant use, there's almost a one-to-one relationship between where your ESRT level is located and where the behavioral upper stim level is located. So that is not merely just a correlation. A correlation just means that they're related. This is actually a one-to-one relationship, which means that where your ESRT level is pretty close to where their upper behavioral, like M or C level is going to be located. So that's a pretty big deal. I mean, that gives us very valuable and highly useful clinical information. Now, over time, there is research to show that ESRTs do increase over time. So there's a lot that still needs to be looked at. Generally, people, clinicians such as myself, I typically am going to be measuring these ESRTs in the first year of use. We typically start measuring these in our patients at about 1 month post-activation. We typically are going to get, through the entire array between 1 month and 6 months. 1 month for sure for adults, if we can get them to sit still and not tell us every time they hear it. Children are going to take a little longer for sure. But once we get those measures, we don't necessarily even have to be concerned with where these responses are over time. And I'm going to show you what I mean by that in a moment. So what you're looking at here is these are some data from a paper by Jace, Wolf, and Casales from 2008. And what they looked at was clinical units on the y-axis as a function of the different, these are AB devices, so different groupings of electrodes. So E1 through 4, here, 5 through 6, 9 through 12, and 12 through 16. What they did was they created conventional behavioral maps determining upper limits of the M levels for the patients using just standard behavioral measures of loudness growth ratings. And then they measured ESRT maps. And what you can see is the ESRT maps, so what we've got here is the squares tend to be set at slightly higher than the behavioral maps. For most of the array, they were much closer in the basal cochlea. Moving along. Then what they did was they measured some speech perception scores for speech understanding in quiet using hint sentences and noise. I'm sorry, speech recognition in quiet and noise. So they had the hint sentences and noise, as well as CNC words at 50 dB SPL, 60 dB SPL, and 70 dB SPL. And for the conventional behavioral program, here were the mean scores for the 11 participants in the study. And here were the mean scores for the ESRT-based maps. Now, what's important for us to know is that on a statistically significant level, these scores were not statistically significantly higher. However, what you can see is that in every case, the mean was higher for the ESRT map as compared to the behavioral map. And they do mention also that no one got worse. So that's a really important concept that although this might not have reached statistical significance at the group level, potentially because it's a relatively small sample size, you're seeing that you're not making your patient any worse and potentially trending towards higher performance. Here's a table from the Hughes 2013 book. Another, again, I'm really going to plug that book. I think it's fantastic. If you want more information, I definitely would recommend getting it. What they did was they highlighted just a number of studies that have looked at trying to get ESRTs in a group of patients. And then they track here the number of subjects in each of the studies that actually had measurable ESRTs. And so this was primarily with a 226 hertz probe tone. So that's an important part here too. Or the study didn't specify. So what you can see is the range was anywhere from 37% of patients up to 80% of patients getting a measurable ESRT. I want to focus on this next study, which just came out last year. I think this is a very important study to point out the fact that, again, we might need to be changing our strategy and using, going beyond the default, so not just using that 226 hertz probe tone. So this was a study by Jace, Wolf, and colleagues. They had 23 participants, and they measured ESRTs in all 23 of them. So they were actually able to measure ESRTs in 100% of the participants in that study. Now, I think what's important here is that they looked at, oops, sorry. So they looked at 3 different probe tone frequencies, 226, 678, and 1000. And what you can see is that the averaged or the average level in clinical units where they measured the ESRT did change as a function of the probe tone. So the ESRT was highest, or was elicited with the highest stimulation level when you had a low probe tone frequency, and then slightly lower ESRT levels with 678 and 1000. Now, I can't really make any conclusions on the basis of a 23 patient sample, but I think what's important for us to start to think about as we use these measures in our clinic is which probe tone did we use, and thinking about maybe what relationship that ESRT may be to the patient's actual behavioral upper stim level. And if I don't get an ESRT, can I just change the probe tone and potentially see a response? And I can tell you that I've been using ESRTs pretty much on every single patient that I've seen for probably, I would say, maybe six or 7 years now. I truly believe it's changed the way I practice. I don't know that my patients are doing any better or worse than they used to be, but I now have a target. So like we talked about in the first module, in the more simple, more basic programming, we have a target of where we should be. Whereas when we just do our behavioral thresholds, we really have no idea. It's like a blank slate. We're here, if we can get a beautiful ESRT measurements, we kind of know that's kind of as high as we want to go, because that's the level that's going to be eliciting that stapedial reflex threshold. And we don't necessarily want our patients walking around eliciting the stapedius reflex with high presentation level stimuli. So it gives us sort of that upper target, which is something that we've lacked in cochlear implant audiology, whereas it's something we have in our hearing aid practice. So it really provides a nice guideline for us as far as upper stim levels. And then, of course, on the flip side of that, audiometric thresholds or aided audiometric thresholds with our cochlear implant, providing us a target for those lower stimulation levels. Okay, so you can probably get that I am a fan of ESRTs. I'm a fan because the data support that it is not only highly correlated with upper stim levels, but close again to a one-to-one relationship. So it's not just a correlation, it's actually providing us with information about where to set these. But there are going to be some disadvantages. So let's first talk about the advantage. Obviously, we know it's going to give us an estimate of where those upper stim levels are. So it's going to provide us with that roadmap of where to place those M or C levels. There are limitations for sure. It doesn't really provide us with any estimate of where we should be setting our lower stim levels or the T levels, which is fine. We have our aided detection thresholds for that. You do need additional equipment. So if you don't have access to an admittance meter, you will need to get one, or potentially maybe move your programming into the sound booth where it resides for that one particular part of your clinical appointment. A big one, of course, is the patient has to be still. And if you've worked with your patients and they for years have, pointed to the loudness chart or have raised their hand, it takes a little bit of counseling to teach them, like, I don't need to know every time you hear it, because a lot of them will want to go, that's a 6, or that's loud but comfortable, and then of course it destroys that response because the compliance goes all over the place. It's not, the ESRT is not going to be present in every single patient. And if it's present, maybe it's not present that day due to middle ear dysfunction, PE tube placement, a number of things. We still don't really fully understand what the prevalence of ESRTs are. That Wolf et al. Paper from 2017, it just came out, showing 100% of people having them. So I think we really have to look at this a little bit more carefully. And it's very possible that the reason that they hadn't been measured in the past was simply due to the probe tone that was used. So we do need to look at that a little bit more carefully. And of course, with younger children, this is really difficult. Again, I sort of feel like I need to grow an extra set of arms, because you're like, stimulate, go, trying to keep the kid from moving. Older children, preschool to school age, piece of cake, give them an iPad, let them watch a movie, have them be, relatively quiet and still is great. Toddlers, it's difficult. it absolutely is difficult. So these are the limitations. Moving on to ECAPs. So this is actually electrically evoked compound action potential is the objective measure that most people who work with cochlear implants, it's the one they're most familiar with. Although most people are going to refer to this as NRT, irrespective of whether or not the patient has a cochlear device. NRT, NRI, ART, again, just marketing terms for what truly is the ECAP. So I'm going to be referring to this as ECAP. They're all the same thing. Okay, so the ECAP. So this is a nice, let me pull up my pen again. Okay, over here on the left, what you see is a figure, which is just showing the response. You can see the morphology of the ECAP here. And this is showing you a clinical level of 175, and then going up to 180, 185, 190, and then all the way to 205. And what you're seeing is nice growth in this response as we would expect. So the ECAP is really well defined by N1 and P1, so your negative and your positive peaks. Your N1 is going to occur anywhere from 0.2 to 0.4 milliseconds, with the peak of the response at 0.6 to 0.8 milliseconds. Now, this ECAP is really essentially the electrically evoked analog of wave 1 on the ABR. So if you're familiar or you work with ABRs, or maybe you haven't for a while, an acoustically evoked ABR, typically the latency that we see for those is approximately on average about 1.5 milliseconds. So you might be thinking, well, why is this so short in terms of the latency? Well, think about, with an acoustically evoked response, we're presenting through the outer ear, through a insert earplug, and then it has to travel through the outer ear, the middle ear, through the inner ear, and get to the auditory nerve. Whereas with the ECAP, we're actually stimulating in the cochlea itself and then measuring right there in the cochlea. So it's a near field stimulation and a near field recording. So the latency is going to be substantially shorter because it doesn't have to travel through the outer ear, middle ear, and through the hydromechanical intercochlear system to get to the nervous system, or to the first point of the primary auditory neurons. So it's going to be a shorter latency for sure. The other thing that's important for us to know is that the response amplitude can be quite large, up to 2 millivolts. In contrast, wave 1 on an acoustic ABR is typically like 0.3 to 0.5 at most microvolts. And again, the reason being that that is a far field stimulation and far field recording, because you have surface electrodes that you place for an acoustic ABR, or even a bone conduction ABR. You have surface electrodes. With an ECAP, your stimulating electrode and your recording electrode are both near field. They're both there in the cochlea. And so the response that you see is enormous. And so, thankfully, all modern cochlear implant systems, so all 3 of the FDA-approved systems, have this bidirectional telemetry. And so telemetry, we hear this word thrown out a lot. It's, I'm sure most of you know, but if you're not familiar, it just has to do with data transmission, primarily through a radio frequency source, from a source to a receiver. So it just means that it's transmitting data. ECAP, as I mentioned, it's essentially the electrical analog of wave 1 on the ABR. Explained the morphology. You've got this nice negative and then positive peak, and mentioned the amplitude as well. This is a relatively old figure. I got this figure from this paper from 1999, so some of the terms are a little bit kind of outdated. So what you can see is here, they've got, like, for example, a banded electrode array. Don't worry about that. The diagram is still accurate. So basically showing that you need the computer, your speech processor, the transmitting coil, the internal receiving coil, the receiver stimulator package, and then the implanted electrode array. And you've got your forward transmission here and your backward telemetry here so that you can measure the ECAP. Okay, so what are the advantages? There are actually a lot of advantages of ECAP, which is probably why most people use them. It's convenient. It's built right there into our cochlear implant software, so you don't need anything extra. It's all right there. It's near field recording, huge responses. And for those of you who've already used it, you know that the patient can be kind of moving around, especially little kids, they can be kind of playing with things, and you can still measure it just beautifully. No sedation needed, and they don't have to necessarily be sitting super still. Of course, they are still tethered to the programming hardware. There are some limitations as well. The stimulus is large. And so even though the response is relatively large as compared to like a far field recording, you still have to deal with the potential stimulus artifact, which we're going to talk about in our live online class together. And again, there's lots of ways to get around this, and we essentially, and by we I don't mean me, I really had nothing to do with any of this, we as a field have really had nice artifact reduction techniques that really are getting rid of this, these limitations, and we'll talk about that a little bit more in our live online class. Okay, accuracy. Now, as I mentioned earlier, this is the objective measure that most people use and most people are familiar with. And I think it's really important for everyone to be aware, if they're going to use this, of what the accuracy of the ECAP measure is. So ECAP thresholds, so your T, NRI, TNRT, TART, they are absolutely going to be within your recipient's audible dynamic range. So wherever that threshold for your ECAP is, they should be able to hear that response. Should. And ECAP thresholds are generally, not always, below behavioral C levels or M levels. That's it. So, moving on. So remember this figure from the last time. So this was, we're looking at on the y-axis, we've got stimulation level in clinical units. And then along the x-axis, we've got duration of implant use in days. Lower dashed line, behavioral thresholds. Upper blue dashed line, behavioral comfort levels, or CRM levels. You can see where the ESRTs are by about, 4 to 6 months in, the one-to-one relationship. ESRTs do tend to continue to increase over time. ECAPs, on average, are well below where the person's upper stimulation levels are to be set. Now, some people might think, well, that's fine, so I'll just go ahead and determine the profile for the thresholds and then increase and decrease the upper stimulation level profile, the M profile or C profile accordingly. That is a very commonly used strategy, and I'm going to show you why. I'm going to show you hardcore data, why that might not be the best use of your programming time. Again, ECAPs are really great for intraoperative purposes. For example, you can go to the family and say, we saw beautiful neural responses. It gives the patient's family immediate sort of peace of mind, like, oh, okay, the implant works. It's stimulated, they stimulated the nerve and we're able to see responses. Great. But here's the flip side. If you don't see ECAPs, it doesn't necessarily mean that that person won't get auditory percepts with that cochlear implant. So we'll talk about that a little bit more as we go forward. So let's look at this paper. This is from Pollock and colleagues, 2006. And what they did was they took 30 N24 recipients and they obtained ECAPs as well as ESRT thresholds. And then they created 3 separate maps. So they created maps guided by NRT or ECAP thresholds, by ESRTs, as well as behavioral C levels or behavioral upper stim levels. And here's what they found. So I'm going to show you a figure, but I'm going to give you the punchline now. So NRT, ECAP, great amount of variability amongst patients. So from patient to patient, lots of variability, and also from electrode to electrode, which is an important part too. And there's a modest correlation with NRT thresholds and upper stim levels or C levels, but with the thresholds for ECAPs tending to underestimate where those upper stim levels should be placed. On the other hand, ESRTs have very low variability, and very high correlation, almost a one-to-one relationship, with the upper stimulation levels where they should be set. Here's 2 more points. 1, the postlingually deafened patients in this study reported that they had a preference for the programs that were created with the ESRT, so the ESRT maps essentially. But on the flip side, the prelingually deafened patients did not prefer the ESRT maps, and I'm going to show you why on this next figure. So what we're looking at on this figure is we have on the left, we've got the postlingually deafened subjects, and then on the right, we've got the prelingually deafened subjects. I want you to focus on the left for just a moment. So this is the programming unit, so this is actually just clinical levels, and these were all cochlear recipients, so this is just like CL levels. And you can see here the different electrodes from 20 moving down, so we've got the basal cochlea over here, and the apical cochlea here. Now I want you to see where the behavioral C levels are the triangles here, shown right here. The NRT thresholds are these diamonds, which I know are hard to see, but I'm sort of trying to mark on the screen. And then the ESRTs are these squares here. So I have a circle here around the ESRTs and the upper behaviorally set C levels. And you can see that these are almost on top of one another. If there's anyone that's higher, it does tend to be higher for ESRTs as compared to the behaviorally set. NRT base maps, however, tended to be set much lower, and that's not surprising for those of us who pay a lot of attention to these ECAPs, knowing that they do tend to be lower than behaviorally set upper stim levels. And then here are our T levels all the way down here. Okay, prelingually deafened. This is the important part. So the C levels behavioral are these triangles, and the ESRTs in this case are actually below where their prelingually or where their behaviorally set C levels are. So this is probably not terribly surprising, because we know prelingually deafened subjects who are, prelingually deafened adult patients who are implanted as adults do tend to have, they have like a lot of power because they've used, high power hearing aids their whole life, and it's often that they have higher upper stimulation levels than our typical kind of postlingually deafened adult cochlear implant recipients. So the report was that these people do tend to like having their behavioral maps because it was perceived to be louder. But then we have to think, are they potentially being overstimulated? Would they be better if we were to lower their upper stim levels? Just kind of food for thought. Okay, we're almost done. So this is one more paper that I want you to just kind of think about. I'm going to just summarize it for you. It is a systematic review of 25 peer-reviewed papers that have specifically looked at kind of what's the relationship between ECAPs and overall speech perception outcomes. There's a lot of papers out there, and there's conflicting data. So they were able to come up with 2 primary conclusions on the basis of really reviewing all 25 of these papers. Number 1, if the patient does have ECAPs, so physically we can measure them, these people do tend to have better speech perception outcomes as compared to people who don't have ECAP measurements, which is probably not terribly surprising. Secondly, the slope of the amplitude growth function for the ECAP, so we know as we measure, we're increasing that stimulation level, we're going to see that growth of response go up. That does tend to be correlated with speech perception outcomes. So steeper slopes, so higher growth of the response with increases, tend to have better outcomes as compared to the more shallow slopes where you see less increase in the ECAP with increasing stimulation level. And we're going to talk in our case studies about that actually does make sense because there are some animal data that have shown that the slope of the amplitude growth function may actually be a biomarker for underlying neural health, which we'll talk about when we get to our case studies. So that's all there is about that. So I think you want to be thinking about in your practice how you're using your ECAP responses, and if you're using ESRTs, and if not, before we meet for our live course, I really encourage you, I want you to take at least one patient, get their ECAPs, and then measure ESRTs across the array, And I want you to think about the relationship between those thresholds for ECAPS and the ESRTs and how that might help you program that patient. Thank you for hanging in there with me. I'm a little tongue-tied today. It's a Monday. So I appreciate everyone, and I'll see you in a bit. Bye.